sponsored and hosted by Albany IVF, an affiliate of Boston IVF. We are so glad to have you with us on this webinar. This is the top 10 questions to ask a fertility doctor. We are very, very excited to have with us tonight Dr. Sonia Elguero. She is a reproductive endocrinologist, a board-certified obstetrician and gynecologist, and she lives and practices in Albany, New York with Albany IVF, and they are a Boston IVF affiliate. This webinar is recorded and will be available with Resolve's website as well as Albany IVF and Boston IVF. Dr. Elguero, thank you so much for joining us tonight and for answering these top 10 questions. Now, I realize we only have about 20 minutes to get through these top 10 questions, so I know you're going to give us very wonderful information, but I just want the listeners to understand that there's a great deal of information on each of these questions. We've asked Dr. Elguero to try and keep her answers short so we can get through all 10 questions, but please understand that each one of these issues has a great deal more to them, and there's a lot of information on the Resolve website and the Boston IVF website as well on many of these issues. So Dr. Elguero, thank you so much for joining us.
Thank you, Barb, and good evening to all the listeners out there.
I'm going to go ahead and jump right in and get started with our first question. So this is a question that we get a lot at Resolve, Dr. Elguero. How many IUIs or intrauterine inseminations should someone do before they move to in vitro fertilization?
I get this question a lot in the office as well from many patients, and really what we know from studies is that after 3 cycles of intrauterine insemination, we know that pregnancy rates are significantly lower. Now, there was a recent study that was published just 3 years ago in 2011, and the purpose of that study was really to look at this, to look at the relationship between number of IUI treatment cycles and the subsequent pregnancy rates. And the study looked at about 400 couples who were presenting for an infertility evaluation, and what they were measuring was pregnancy. And they found that couples who completed 1 cycle and then 2 cycles and 3 cycles of IUI were more likely to achieve pregnancy. And importantly, there was no additional benefit seen for couples who were using 4 or more IUI cycles. So interestingly, in addition to this, they also looked at medication only and IVF, and what they found is patients on medication only, so an example of that would be Clomid, for example. After 2 cycles, the success rate diminished just as it would after 3 IUI cycles. And similarly, couples using 3 or more, IVF cycles also had a lower likelihood of achieving pregnancy. So certainly, when looking, at the decision of how many cycles to do, it really is important to look at the whole picture and to really balance the side effects of the treatment, the age of the patient, which is very important, their ovarian reserve, and the effectiveness and cost of the treatment.
All right, that is very good information. Very interesting, too, on the studies looking at some of these issues. All right, question number 2. This is a question that actually came from one of Resolve's constituents, but I'm sure, Dr. Elguero, that this is something that comes up a lot in your practice. So I am over 42. Should I try IVF with my own eggs or move, and I'm sure this is moving right to donor egg. What are my options?
So we know that the success rate of in vitro fertilization once a woman is beyond the age of 42 using their own eggs is quite low, so it's approximately 4%. That's the live birth rate. In an individual who's over 42 with a diminished ovarian reserve, really the only effective option at that point is proceeding to donor egg. That's an important distinction, being over 42 with a diminished ovarian reserve. And alongside of this, it's important to really take note that, even if you do get pregnant and you're in that 4% range, that live birth rate, that there is an increased risk in spontaneous abortion, fetal chromosomal abnormalities, and that's really inherent to the age of the egg. So that risk is going to be there. And on the converse, using donor eggs, those risks are dramatically reduced because ultimately it's the age of the egg that increases the risk of these risks that you can see here, both the abortion and having a fetus with chromosomal abnormalities. In terms of honing in a little bit more on the donor cycles, if you have a patient who's over 42 with a diminished reserve who does proceed directly to donor, it's also important to note that there are still risks to that patient related to the patient's age, including gestational hypertension, which is high blood pressure, gestational diabetes, and the increased likelihood of cesarean section. So those risks are inherent to the age of the patient, aside from the age of the egg, but it's important to take note of that as well, even if a patient over 42 is proceeding to donor egg directly.
And oftentimes we get this question, and I don't think that the patient is expecting or anticipating that conversation about donor egg. And so, I think that this is really great information to know that this is based on data and studies, and that, most of your colleagues across the country are probably going to give this patient the same information and the same recommendation.
I agree.
So let's move on to question number 3. We've also received this question. My male partner is reluctant to get checked out by a doctor. Any information you can suggest that will help get him to the doctor?
That's a great question, actually, and I have a lot of patients that come in on their own without their male partner, and they indeed relay this information and say, well, what do I do? They ask me directly, and I think, that reluctancy is often twofold. I think on one hand, there's a reluctancy because there's a fear of, undercovering a problem, and you don't want to feel that you are the reason why your female partner is not conceiving. And I think on the other side, the reluctancy can often be related to the unknown. Well, what's going to happen, and what does being checked out mean? And I think a big part of that is, many males don't talk about this, and it can be a very personal, private issue. And I think oftentimes females can bond and communicate with their infertility problems, but I think for many males, that reluctancy can stem from just lack of communication and lack of knowledge about again, what does checked out really mean. So I think related to that, it's important to note that male factor actually contributes to about 20% of infertility. And importantly, many factors can be reversible. So for example, if a patient was taking testosterone supplements that can affect their semen parameters, that can obviously be reversed by stopping the supplementation. There can be anatomical issues such as varicoceles, which again can be reversible through surgery and removing the varicoceles. And in addition, there can be medical reasons, including uncontrolled diabetes, for example, which one may not think that could affect the semen parameters, but indeed it can. So I think that's very important to know that if you do identify a problem, in many situations it can be fixed, it can be reversible. The other important piece of information is that when the male partner is being checked out by the doctor, these doctors are typically urologists that specialize in this area. They specialize in male infertility, and I think that can be very reassuring for the patient to know that they're seeing an expert in the field. And the final point is that, oftentimes, the initial evaluation really consists of a semen analysis. And usually if it's normal, that's where things end. And the actual process of collecting the semen, that can be very easy. I mean, most centers, you can collect at home and simply drop off your sample. So I think that makes it easier to actually go through the process.
Well, and your first bullet here is so important for people to know and to talk about, and this is certainly one of the big myths about infertility is that it's just a women's problem.
Absolutely.
And I think that, yeah, I think that being able to recognize this, and I cannot tell you at Resolve how often we hear of women going on medication and having procedures and months and months and months, and then never was their male partner checked out. And this is, as you probably have described here, it's not invasive, it's low cost, and it can rule out, let's face it, 20+ % of the problem, and incredibly important to have done. So hopefully the data and information you've provided helps get more guys to get checked out.
Mm-hmm.
All right, let's move on to question number 4. How long can embryos stay frozen?
Well, theoretically, embryos can stay frozen for a long time, in other words, an indefinite period. And the reason for that is they're biologically inactivated during the cryopreservation or during the freezing process. I think when you're answering this question, there are other components, and one of the main components is the actual practice, where the embryos are frozen and the type of quality control that practice is maintaining. So, for example, what are the levels in the tank? The alarms, that are present on the tank. I mean, there are a lot of quality control issues that are involved with freezing embryos. Another important point is with our new freeze technique that we're using called vitrification, which is an ultra-rapid freeze, embryos are actually stored in a smaller volume compared to the slow freeze method. And really, because, this is, how we're freezing now, there's really not a lot of long-term data, on this. But like I said, theoretically, one can assume that, they can really stay frozen for an indefinite period.
All right. Very good to know for those that have frozen embryos and are wondering if they're still viable or not. So question number 5. Wow, we get this question a lot. I am wanting to take a break from treatment, and I'm assuming here they mean medical treatment, but I'm not sure how to tell my doctor. Do you have any advice?
Well, I think this is really, a key question here. I think this is quite critical to really, share that with your doctor. And, as you can see, I've written here, it's important to be open and direct with your doctor. And, that's also reciprocated. Your doctor wants to be open and direct with you with both counseling and with the recommended treatment options. So ultimately, that communication is key. And I think a big part of that is, it's not easy to, continue with treatment back to back, especially if you have a very hectic lifestyle and you work and you have other responsibilities. And, going through treatment can be a very stressful process. So that's very important to share that with your doctor so that they can help you with, taking a break and coordinating the cycle and, offering you treatments, for stress reduction, if that may be the case. So I think, it's very important to, feel that you can be open and communicate this with your physician. They want to hear it.
Well, you just said it. They want to hear it. So, some people are afraid. They sort of feel like, are you going to, it's like a breakup. Are you going to have hurt feelings? I think, and Dr. Elguero, please help us with this. I mean, I think some patients are afraid to have this conversation and they just stop. because maybe they're afraid the doctor's going to pressure them or is going to say, oh, no, let's try something else. And, you know, like, you're the physician. Is that the case? Is that what you're going to do?
It's truly not. I mean, you know, my number one priority is to know, how does my patient feel? And like I said, going through treatment can be very stressful, especially if it's back-to-back. There's a lot of components. You're coming in, you're being monitored, you're having blood drawn. That can be every 2 days. It can, in an IVF cycle, it can be daily as you get towards the end of the cycle. I mean, all of this is very disruptive, certainly, if you have a very hectic lifestyle and other responsibilities. And to go through that again, back-to-back without a break, can be very challenging. So I would want to know, you know, as a physician, so I can help my patient plan accordingly and lower their stress, or make the cycle easier.
Wow, that is really, really great to know. I have never asked this question of a doctor, question number 5, so I so appreciate your insight from your perspective. Question number 6. I have PCOS, which is polycystic ovary syndrome, and you know, I'm sure many of the folks on this webinar know that a huge percentage of women have PCOS, and it's one of the leading causes of infertility in women. But does this automatically mean I have to do IVF to have a baby?
Absolutely not. I mean, it does not mean that you have to automatically go to IVF if you have PCOS. An important point that you can see here that's listed is that weight loss, even as less as 5% of your body weight, just losing 5% of your total body weight, can actually restore ovulatory cycles, which is actually remarkable, you know, to have that control. You know, you have control over your weight loss and your lifestyle, and that can actually resume your ovulation. I think that's a very important factor to understand. That being said, you know, for someone who, for example, has attempted that and hasn't been successful, there are many other options to induce ovulation, you know, ranging from Clomid, or clomiphene citrate is another way to describe Clomid, letrozole, injectable medication, and, of course, IVF. And I think, you know, obviously this cannot be a cookbook recipe for every patient, you know, with PCOS. The care really has to be individualized. And, again, we have to balance the side effect of that particular treatment with the age of the patient with PCOS, their ovarian reserve, and, again, the effectiveness and cost of that particular patient. So we really have to look at the whole picture of a patient with PCOS. It cannot be a cookbook treatment.
That is the key message. I also want our listeners to know that there's a lot of hope for those with PCOS, because there's a lot of research that is going on in the field specifically around PCOS. In fact, it's probably one of the most researched areas right now in infertility. And you know, you mentioned letrozole, and I mean, I think that this treatment field is evolving and growing and improving for people with PCOS, maybe even, you know, from 5 or 10 years ago. So, but I think the key message here is exactly what you said at the end, is that every single person is individual and needs to have an individualized treatment plan.
Absolutely.
So let's go to question number 7. Are there any studies on the health consequences of taking fertility medications? And, you know, I know there's a lot of different medications, so I maybe you could be specific, too, on which ones you're referencing, because as people who go through, not necessarily all IVF, but maybe those of us who have gone through IVF, we do take a lot of different medications.
Sure. So this is a very broad question. I guess if we break it down and look at short-term consequences related to the treatment and long-term consequences, if we hone in on the short-term or the immediate consequences, those include ovarian hyperstimulation, which of course is more inherent to an injectable cycle, particularly with IVF. Multiple gestation, which can be with Clomid, with injectable treatment, even with IVF, depending on the number of embryos which are placed. back in the uterine cavity, ectopic pregnancy, and adnexal torsion, which is essentially the ovary gets twisted upon its pedicle, and it can result in significant pelvic pain requiring laparoscopy for detorsion of the ovary or untwisting of the ovary. So those are some short-term or immediate health consequences that can be related to fertility medications as a whole. Now, when we're looking at long-term, I guess, health consequences, the common thing that comes to everyone's mind is cancer, ovarian cancer. We're stimulating the ovaries. And a lot of patients will, come forth with that question because there's an anxiety. You read something on the internet or you've read a study or something on the news is a very common question. So, what we know already is that there have been numerous epidemiological studies which have really looked at the link between fertility drugs and risk of ovarian cancer. And the bottom line is that most have really found no strong association between fertility drugs and risk of ovarian cancer. Now, interestingly, just recently, actually this month, November 2014, there was a paper that was published where they looked at a very large group of women. So a little over 96,000 women were in this cohort study. And what they found was that when you look at the risk for borderline ovarian tumors, and those are tumors with a low malignant potential, they found that the risk for these tumors was really not associated with the use of any fertility drug, whether that was injectable medication, Clomid, the trigger shot, which is HCG, or even Lupron. So, this was a very large study that was published recently, which again supports the fact that there really is no strong association.
Well, I'm sure that is very, very good news for many people who are listening. Let's move on. Question number 8. Is egg freezing only for women who are going to undergo chemotherapy or radiation? And this is, as you know, but for our listeners, this is for a woman who may have to undergo chemotherapy or radiation because of a cancer diagnosis or some other condition. And by doing so, they're going to compromise the health of their eggs. And so they want to preserve those eggs and cryopreserve them prior to starting this chemotherapy or radiation. So are they the only women today who should be doing egg freezing?
Well, they are certainly, a very important group of patients who want to preserve their fertility during a very difficult time. However, importantly, the American Society of Reproductive Medicine has announced that egg freezing is no longer considered experimental. And how that impacts on candidates for egg freezing is that women can certainly consider egg freezing to stop their biological clock, without a diagnosis of cancer. So you don't just have to have a diagnosis of cancer and be undergoing chemo to be a candidate for egg freezing. And I think that's something that's certainly a benchmark in our field, and it's very exciting that women can actually have this option. So, for example, you could be hypothetically 35 and not have a partner or not desire a partner, and you have the option of presenting to a fertility clinic and undergoing testing to determine if you are a candidate to freeze your eggs. So when I talk about candidate, what I'm talking about really is undergoing ovarian reserve testing, to really see, are you suitable? I mean, certainly age is a major driving factor, but it is certainly important to look at a patient's ovarian reserve to determine, how many eggs are we capable of getting, and ultimately, is this a suitable option for that particular patient?
All right, that is great to know. There's a lot of buzz, certainly in the media, about egg freezing right now. Question number 9, we just have 2 more questions to go. This is, when I go through an IVF cycle and multiple eggs are retrieved, am I depleting my egg reserve? So we just had a question about checking your ovarian reserve, and now wondering if as we remove all those eggs in an IVF cycle, are we actually harming our reserve of our eggs?
So this is a great question and a very common question. So in a typical cycle, in a normal menstrual cycle, what happens is, a group of follicles is recruited, and that's through stimulation from FSH, from the pituitary. And one of those follicles becomes a leader, or, the dominant follicle, the leader of the pack. And I think what most patients don't realize is they think that, well, gee, all those other follicles, they're going to go back into the pool, and I'm saving those eggs. But that's not the case. Those remaining follicles that are growing up and making estrogen, they don't go back into the egg pool. They basically undergo atresia, which is the medical term for meaning, they are gone from the pool. They're atretic. They basically they have undergone a death, and those follicles and those eggs are gone. With IVF, what we're doing is it's the same group of follicles that are recruited. In fact, we're actually bringing them all forward. Instead of them becoming atretic and leaving the pool, we're really bringing all of those follicles and those eggs forward. So really an easy way to think of this is really, instead of waiting 10 months and you're waiting for 10 eggs, you're really combining 10 cycles into one. That's kind of an easy way to think about it. So you're shortening the time to conception. So really, going through IVF and going through any form of fertility treatment, in fact, is not depleting your eggs or depleting your egg reserve.
Wow, very interesting, and obviously good to know as well. And our final question of our top 10 questions: are frozen embryo transfers inferior to fresh embryo transfers? And what a great question, since we just talked about, are we depleting our eggs? Because certainly if we do get multiple eggs and they fertilize and then we have multiple embryos, we're going to have a lot that we want to freeze to lower our risk of a multiple birth. So for subsequent pregnancies, are we going to have inferior results than that first fresh transfer?
Sure. So it's actually quite the opposite. I mean, we know from studies that frozen embryo transfers can result in improved IVF outcomes compared to fresh. And much of the reason is when you think of a fresh cycle, you really have high levels of estrogen and progesterone floating around. So you have super physiologic levels of both of these hormones. And what that can do is, it can result in, an asynchrony between the embryo and the endometrium. And it's important that both of these be in sync. They should be marching down the aisle together in sync. When you look at a frozen cycle, you don't have these high levels of estrogen and progesterone. It's more physiologic. It's not super physiologic because you're just honing in on the lining. You're honing in on preparing that lining, and the embryos are already made. They're made and they're frozen. So if we look at further evidence for, why a frozen cycle can be more successful than a fresh, when we look at egg donor cycles, we look at recipients, we see, a higher pregnancy rate. And again, that could be inherent to the fact that they don't have high levels of estrogen and progesterone because we're just focused on preparing their lining. And same is true when you look at shared egg cycles. When you look at the recipients compared with the donors, again, some studies show that there are higher pregnancy rates in the recipients. And again, that can be related to, better endometrial receptivity because of the environment.
Wow, that is really, really good to know for folks and couples and women who have frozen embryos and are wondering about their future chances of a pregnancy with those frozen embryos. So it's great. Well, Dr. Elguero, I want to thank you so much for answering these top 10 questions. You've done a fantastic job of whipping through 10 very interesting and diverse topics related to infertility. And I have to say you did it in a very succinct way and very clear. So thank you for that. However, if you still have questions and you're listening to this webinar or watching it via podcast, go ahead and email Resolve at info@resolve.org, and we'll do our best to send you to the right information and help you get any further information that's important to you. And you can also go to resolve.org for more information on all family building options. I want to thank Boston IVF and Albany IVF for sponsoring this webinar of this excellent content. And mostly I want to thank you, Dr. Sonia Alguero, for joining us for this webinar and sharing your vast knowledge and compassion for the infertility community. We are very grateful for all that you do each and every day, and we thank you for taking this time to help educate patients.
Thank you very much for having me.
Thanks for joining us, and again, you can go to resolve.org for more information. Thank you. Bye-bye.